Next, we'll be joined by two of our team leaders in the kidney regeneration group, Kathy Quinlan, one of our team leaders and paediatric nephrologist at the Royal Children's Hospital, and Jess Vanslenbroek, team leader in the kidney lab. Thanks.
Excellent. Thank you, Enzo. Now, for something completely different, because we've been hearing a lot about how rare many of these diseases are, and what I'm going to start is by telling you just how common kidney disease is. It affects 11% of the population, which is about 100 people that are sitting in this room right now. Its impact is significant because there are very few specific treatments, and we're really just stuck with symptom management. It contributes to over 1 in 10 deaths in Australia each year, and about 20% of all hospitalisations. Every year, around 5,000 Australians go into kidney failure, but we can only do about 1,000 transplants because of a profound organ shortage. That means we have 28,000 people in this country on dialysis, and that number is going up and up and up each year. So for such an adult disease, it's reasonable to wonder why at MCRI we are interested. And the reason is that over 50% of children with kidney disease have a genetic basis to their disease, and crucially, because we have discovered that an early diagnosis leads to much improved outcomes. Now, the Kidney Flagship is a collaboration of researchers, clinicians, patients and families with a vision to end kidney failure in childhood. And we do this through 5 main streams of research focused on empowering patients, providing an early diagnosis, developing data-led streams of care, finding new and repurposed therapies, and developing transplantable stem cell-derived kidneys.
Thank you, Kathy. Now I'm going to talk a little bit about the treat and the transplant arms of the Kidney Flagship, in particular research that's been driven in the lab by myself, Kynan Lawler, Ord Dorison and Sarah Howden. So the advances we've made in stem cell medicine to date have been a really good opportunity for us to be able to improve kidney disease outcomes. And what I'll talk about a little bit today are kidney organoids, and these are derived from the differentiation of pluripotent stem cells. These organoids hold great promise for a range of applications, in particular disease modelling and drug screening, but potentially also as cellular therapies or for the replacement of tissues in the future. So the key breakthrough we made in the generation of this complex kidney tissue from stem cells came in 2014, when we found that we were able to step pluripotent stem cells through these embryonic pre-kidney stages by the addition of precisely timed signalling molecules and ending with the formation of these complex kidney organoids that are densely packed with nephrons. And the nephrons they contain are well patterned from their proximal to their distal ends, and they're also surrounded by vasculature or blood vessels and a stroma, as you would expect to see in a fetal kidney in vivo. So the opportunity this has given us is to see whether we're able to engineer transplantable tissue from stem cells. And we've been since developing cutting-edge technologies to be able to scale up our organoids and generate more nephrons inside them. And one approach for doing this is 3D bioprinting. And using this approach, we're able to generate these kidney tissue sheets that are larger and more densely packed with a higher number of nephrons compared to our standard organoids in the lab. But the other approach we're using is a scale-out approach to generate these thousands of microorganoids that are cultured in a suspension culture technique, and this is more amenable to scale up to bioreactors in the future for translation. We're also improving our benchmarking of these different conditions that we're using by the generation of kidney-specific stem cell reporter lines, and these enable us to visualise and track the individual cell types in the organoids as they develop. And then we can also look at the development of the organoid ongoingly using 3D confocal imaging and image quantification paired with gene profiling. By harnessing these advances, we've been able to generate these densely packed organoids that are full of blood vessels, and they show increased maturation and functionality of the nephrons inside them. And the techniques that we're using are all reproducible at this increased scale. So we're now mapping the steps from here to the clinic. So we already know from work with our collaborators at LUMC, when we transplant these organoids underneath the kidney capsule, where they're not only able to survive and grow, but they also become connected to the organoid, the host's blood vessels, and also connected to the blood circulation of the host as well. But importantly, the work we're doing now is looking at whether these nephrons can actually plumb into the host and begin filtering the host's blood. We're using 3D image analysis of both the host and the graft kidney to look whether the nephrons of the host and the graft can connect, and also look at the viability of the transplant. In parallel to all this work, we've been improving the accuracy of the disease-relevant cell types that we're generating in the organoids to hopefully improve their ability to use to model and screen different diseases. So we've now been able to model a number of inherited diseases as well as an infectious disease, and we've been able to scale down the organoids that we're making and show the suitability of this approach for drug screening. So the future of disease research using kidney organoids looks bright. There are a whole host of different gene disorders that involve many different cell types and span a whole lot of different genes in the nephron. And one of these is Alport syndrome, and Kathy's going to finish up by talking a bit about this now.
Thanks, Jess. So we've talked a lot about how our patients inspire our work, and I just wanted to introduce you to one of the families that has benefited from some of the work that we've done. So about 5 years ago, I met this man in my clinic, along with his 3 kids. And by the time we were finished, I had diagnosed him and the 3 children with dominant Alport syndrome. Now, dominant Alport syndrome is a genetic, degenerative kidney condition that starts with microscopic blood in the urine and ends with kidney failure. Early diagnosis can delay the need for dialysis by about 20 years, but first we have to actually make that diagnosis. And really tragically, this man had been known to the hospital from the age of 3 with blood in his urine. But he hadn't ever actually met a kidney doctor until he presented at the age of 16 to the emergency department in kidney failure, when it was too late to offer him anything other than dialysis. So throughout his entire childhood, his phenotype was sitting in our paper medical record, and no one even knew that they needed to look for it. Now, RCH was the first hospital in Australia to move to the electronic medical record EPIC in 2016. Every day, in every hospital, as our staff and patients interact with the electronic record, we leave thousands of tiny data points. And over time, those data points start to tell us stories. Stories about our patients, stories about their outcomes, stories about their families. But when we used paper charts, we had no way to look at that data as a whole and to start to look for patterns and pick out patients and children who might be at risk. Moving to electronic records opened up new possibilities, and the Centre for Health Analytics was founded to help us to find the signal in the noise and identify children who might be at risk, a time to offer them an early diagnosis and start treatment. The 3D study for the early detection of disease through data has been led by Dr. Grania Butler, who is a paediatrician and a PhD student at MCRI. And it was developed following a period of consultation with stakeholders from across the campus, including families. We started in 2022, and she identified over 4,000 children in our electronic medical record who were at risk of Alport syndrome. These were all kids who'd had microscopic hematuria that had not been followed up. We then stratified these kids to identify those who were at highest risk and set out to contact nearly 1,300 patients to invite them for rescreening. 262 of them had repeat urine testing, and 16 of them were found to have persistent microscopic hematuria and were invited for a clinical assessment for a metabolic workup and genomic sequencing with analysis of the genes implicated in the development of kidney disease. 15 of them took up that offer. Now, 5 patients right now are awaiting their results, but of the 10 remaining, we've diagnosed 4 patients with Alport syndrome. That's 4 patients where we can intervene and we can, with a once-daily, well-tolerated oral medication, delay the onset of dialysis. Obviously, this is a familial disease, so we've diagnosed 1 sibling, we've got some parents who are waiting for test results, and 4 more siblings who are also waiting for their results. Now, identifying these patients was supposed to be the really hard part of this study. But finding out how you can actually contact 1,300 families who are, known to the hospital but not known to the kidney team turned out to be exceptionally tricky. And we went through a lot of different iterations before we figured out how to actually do that well. But every problem that we have reached and solved has laid the groundwork for the next clinical team to run a project similar to this. And we've created, for example, a suite of patient-facing resources to accompany the letters that we send out to patients. And this project has completely flipped what we are capable of doing as a hospital. Instead of treating sick children, projects like this give us the capacity to reach out to kids while they are at risk, before they are sick, and offer them all the chance to live a healthy and fulfilled life. I'd like to say thank you to all of our collaborators, all of our colleagues, and of course, all of the many funders. Thank you.
Great, thank you, Kathy and Jess. Fantastic presentations. We won't have time for any questions. We're running a little bit over time. That brings this session to a close. It's now time for afternoon tea, and then we'll be reconvening at 4:15 for a panel discussion around the future of child and adolescent health, which will be emceed by Nicola Roxon, the former Australian Health Minister and one of our MCRI board members. See you then.